Welcome back to our daily show. Here's CJ. Welcome back, OSF. Heather, Traci, how are we doing this morning? Is it still kind of dreary out there?
It is. It's very damp.
It's like Seattle out there today, you know, kind of has that just kind of downness to it. Well, I'm really excited about having you guys in studio because any chance we can really talk about the emergency department, it's a really fascinating conversation and an important one because, you know, so many times we might not go for 3 or 4 or 5, 10 years and then we're in there, and it's, you know, how do we navigate it? What are some of the things that we can do to make our experience go a little bit smoothly, but also to gain insights on what you guys encounter each and every day and manage, and it's very important. And with that being said, we can just kind of dive right in if that sounds good. What are some of the roles that you guys do each and every day in the OSF emergency department? And you know, really just from the overview of what you guys do, but also more specifically, some of the hands-on things that you guys are doing each and every day also.
Sure. Well, I'm the director of the emergency department. I'm responsible for kind of overseeing, you know, the operations of the ER. And then Heather.
I'm the supervisor, so I kind of do the day-to-day with scheduling, putting out fires, filling in when needed.
Well, and what's a typical day in the emergency department look like? Because I'm sure that, especially with this, no day's ever going to really be identical. Now, whenever we talk about that, though, there's influxes, I'm sure, and there's different times where maybe it's a little bit busier than others. But typically, what does that look and sound like in an emergency department just for one day?
Well, like you said, no day is the same, so every day is different. We see anywhere from 60 to 90 patients a day.
Wow.
So a 60 day to us is a good day. A 90 day is a very busy day. We see patients of all ages. So we've even birthed babies in our emergency department before. But we see patients of all ages, all types of issues that they're coming for. Maybe they're having stroke-like symptoms or heart attack symptoms, abdomen pain. So we see a variety of illness. And it's usually never boring.
Well, and with that said, I mean, 60 to 90 patients daily, I mean, that's really just an absorbent amount of folks. And when you break that down, how much time do you guys truly have, you know, per patient or per case, you know, to maintain that, you know, keeping the, you know, the line moving to make sure that everyone can receive proper care? Because I'm sure that that's got to be a challenge at times.
Right. So our average kind of time in the ER is around 2.5 hours per patient. So that's, if you averaged everyone out, that's kind of the time they spend with us. But it also depends on what they're there for. Some patients, if they're there for a behavioral health type complaint, they can spend sometimes days with us, unfortunately.
Oh, wow.
Yeah, that's one of the challenges that we're facing right now is the mental health crisis, which is very common among all ERs.
Oh, yeah.
So.
Well, and did your protocols have to change because of the, you know, maybe the uptick or now the case amount that you're seeing of behavioral health, you know, emergencies and situations? Do those protocols change or guidelines change for you guys during this?
Not so much the guidelines, but we have had to hire additional personnel to help keep people safe. So we have what's called behavioral health monitors that sit and watch our patients, provide one-on-one observation for them to make sure that they're safe while they're in our care.
Wow. And, you know, when people come in, I'm sure that, you know, just like not every day is the same, not every individual is experiencing the same thing, you know, obviously, too. And, you know, when someone's coming in with maybe a very serious situation, like when my grandma actually went septic, you know, that was one of those things that she was fighting and we had to go right away and they, you know, really quick in and out. But how do you guys manage, you know, the severity of what somebody's going through and how quickly you can navigate that? Because I'm sure that there's, you know, different categories for what someone's going through.
Yeah, so when patients present to us, they're assigned an ESI level.
Okay.
So basically it's for acuity of their symptoms. And all of our registered nurses are trained on how to identify, you know, what type of level they should be. So based on the acuity of what you're showing up for, that's going to determine what your kind of care looks like. If you're really, really sick, so showing up septic, you need to get back quickly because we need to get you treatment immediately, get antibiotics in you to help improve your care.
What are some more policies and protocols for things like that, if you guys can go a little bit more into it, in terms of, something as severe as, going, facing sepsis or, maybe even a very major heart attack or a stroke? How do you guys look at and kind of monitor that, to keep, patients safe and adhere to those guidelines too?
So we do have different protocols. We have what's called a stroke alert. So when patients present with certain symptoms of stroke, that's actually paged overhead in the hospital, and it alerts certain members of our team so that they know they need to respond and get certain things done quickly. Wow. We also have a STEMI alert, which means a patient is having a heart attack. So that also alerts people in the hospital to prepare for probably what's going to be needed as a cardiac cath on that patient. So we have several different types of alerts throughout the hospital that make sure the right people are at the right place at the right time to make sure the patient's getting what they need.
It's very important. And I'm sure when you're facing patients, especially case by case or, what they're going through, that sometimes they're, not just maybe facing a behavioral health issue, but maybe they're just stressed out and they're going through something that, they're just scared. How does the approach differ from patient? Because I'm sure that, you have folks that are, maybe used to this or a little bit more calm and they're okay kind of navigating this in a little bit more mild tone. But I'm sure there's some that are scared and maybe, make it a little bit difficult to get some basic information out because of that. Is that something that you guys navigate a little bit too?
Yeah, we're used to seeing all types of patients and families and friends. Our team does an excellent job of identifying those type of events where people need a little bit more tender love and care.
Yeah.
They're excellent at de-escalating situations and trying just to get the basic information that we need so that we can care for their loved ones.
Well, and whenever people are visiting an emergency department, and, I think hopefully now it's gotten a little bit easier with urgent cares opening up maybe for some minor things that can get, just taken care of very quickly. But what are some things that we should know when we're visiting an emergency department? Is there I don't want to say guideline or rubric, but when should we really know it's time to go?
I would say if you're having severe chest pain,
mm-hmm.
if you're having difficulty breathing, if you are bleeding profusely and you can't get it to stop.
Any neurological symptoms, so numbness or tingling, weakness on one side of the body versus the other, slurred speech, confusion,
passing out.
Mm-hmm.
Those are all things that can be emergencies. One thing I'd like people to know about the emergency department is we see everything. And while I know some people will show up and wonder why someone's being taken back before them,
right.
What they don't understand is if you have to wait in an ER lobby, that's a good thing. That
Right.
means that you're not the sickest right now. Those that get pulled back quickly usually have some type of emergency that needs to be taken care of as soon as possible.
Well, and I've always thought too about that. If someone, because I've been in an emergency room before, and you can see the folks that maybe get a little bit aggravated because they've been there. But I think the same thing is be a little bit more grateful that you aren't in a high priority status that you need to be seen. And if you're frustrated that you're waiting so long, then maybe you don't need to be here in the first place. And I'm not saying, and I'm sure you guys can't. But to me, it's like sometimes it's just something so minor that somebody's there for, and it frustrates them. And there's some other spots, do you think, like in urgent care sometimes that could, maybe expedite that for them?
Absolutely. Prompt cares, urgent cares, they are...
And OSF's prompt care has a great one down on Godfrey Road, too.
Absolutely. And then we have, we have several physicians' offices that are accepting new patients. So there's always another outlet for those minor emergencies. We definitely encourage patients to use their urgent cares as much as possible. But there are some things, obviously, that can't be taken care of in urgent care, and that's what we're here for.
And what are some misconceptions when people visit maybe an emergency department that you guys are maybe faced with or get some frequently asked questions that you have to dispel? Is there anything that maybe when someone comes in, they are maybe perceived a different way, or they thought the process was a little bit different?
They think it's going to go quicker than it actually is.
Right. Well, and honestly, not being funny about this too, but how do you guys manage the mental side of things? Because, you're not only caring for patients that some are in the dire straits of their lives, and you're dealing with some that are going through behavioral issues, but also you guys are working, because my grandma worked ICU for OSF for a long time and worked in the emergency room forever, and she was working big nights, and it was a lot of work. For you guys, do you have some type of way that you're able to kind of balance that work with your mental health too, and able to manage patients? Because that has to get tough.
All I can say is we have an amazing team.
Yeah.
We really do. We have very low turnover in our emergency department. We're fully staffed. Our team truly is there to serve our community, and they're dedicated. Rarely does a nurse call off in our emergency department, so we could not do our jobs without our amazing team.
OSF is also really good about work-life balance and
Really cool.
making sure that you take the time for you.
See, that's really cool. And it seems like that's becoming more and more of an available thing around the region. I hope it keeps coming, the work-life balance, because it was too much stress, it seemed like, for a lot of years, And with this, too, when people are talking about going to the emergency room, some people just hate the ambulance. They just don't want to get in, or maybe they want to drive themselves, or they'd rather have their husband or wife or whoever take them. Why is an ambulance preferred in some of those settings if they're there and they're willing to take the individual, but they refuse it and go at a later time? Why is an ambulance preferred for transportation over maybe, someone driving themselves or having someone drive them?
So ambulances provide care the minute they arrive on scene. So they're assessing the patient, they're providing treatment, so your care is actually started sooner than if you were to come by private car. I think the misconception that some people have is if I come by ambulance, that means I get straight back to the emergency department and get a room.
Okay, I always thought that.
Yeah, that's not always the case. Again, the nurse is going to triage the patient to see how sick they are. And if they're not the sickest, they may have to go back out to the waiting room to wait a little while until another room opens up. But, if you're calling 911 because someone has collapsed or someone's having difficulty breathing, things like that, it really is important for them to be transported by ambulance so that they can get that care started immediately.
100%. And if myself or maybe even a loved one has to have maybe that extended stay because that emergency room visit results in a little bit longer, what should we bring in those situations too? Because sometimes, and I've seen it just in my experiences, someone brings the whole kit and caboodle and kitchen sink with them, and then there's people like me that are very unprepared. It's like, oh shoot, where's the phone charger? Is there any tips that you could maybe provide to somebody that if they have to go extended for a little bit, what are some of the tools to bring or some of the commodities?
Well, nowadays I would definitely say bring your phone and bring your charger. That's our form of entertainment now. But if you have a book that you're reading or a crossword puzzle that you're bringing or that you're enjoying, I would bring those things that kind of give you comfort. If there's a picture that's at your bedside, that you like to look at before you rest at night. Those type of things. You don't need to bring any of your basic needs. We will handle all of that for you. You don't need to bring a toothbrush necessarily or any of that. We have all that kind of stuff. But anything that brings you comfort, to kind of pass the time while you're with us. Now,
should it be one of those things that, like an iPad or something that's pretty valuable, should those things kind of stay at home, or one of those things that if it's worth, the comfort for you, go ahead and bring? What are your thoughts?
Yeah, I think if that's something that you do every night, if you're sitting on your iPad before you go to bed or during the day you're doing crossword puzzles on it, it's safe to bring it. Just make sure that you let your nursing team know, hey, I brought my iPad. At night, if they want to, we can lock it up for them.
Really cool.
So that they don't have to worry about it, disappearing on them. But those smaller things, I wouldn't bring, your laptop and all of that, just because you're there to rest.
Right.
And that's what we really want to stress with our patients is, this is time for you to get better. Maybe work needs to wait a little while you're with us so that you can heal.
Well, and honestly, too, if someone's going in maybe to, right there into the emergency department with their loved one, sometimes, they're a little bit more fired up than the individual because, they're a little bit more, scared than the individual because, they're watching their loved one go through maybe a medical event or a cardiac event. What are some of the ways that, if you guys could, if you have any thoughts on how we could kind of maybe check ourselves a little bit and use some distressors before we walk into the emergency room, because you guys are trying to learn just as quickly as you can the answers that we're trying to ask you for right away sometimes, and I don't think that's fair.
Well, I think just remaining calm and staying kind. It's okay to ask questions. That's what we want. We want you to ask questions about your loved one. Remembering that we're there to help. We're not there to hurt. The patients are our number one priority, and just if everyone just maintains a calm, demeanor, it really does go a long way, both for us and for the patient and their families.
Absolutely. Heather, what are your thoughts on that?
I think just remembering that we're all people.
Yeah.
So, you guys are fired up because this is your loved one. And while we may not be showing as many signs on the outside that we're as stressed and anxious about it, we're still people and we do have feelings, and just being kind. Mm-hmm. We will answer any questions that you have, but don't yell at us. And while it may seem that we're not as affected by what's going on the outside, there's a lot of times we walk away from a situation and, go cry in the bathroom, especially on those terrible situations. It's hard for you, but it's also hard for us.
100%. And if someone's in the emergency room, or maybe they're at their home and someone notices that they've fallen out in the yard doing yard work, you name it, and they actually let's something where they have a power of attorney, but they're not there present with them. How does that process work whenever someone can't speak for themselves legally anymore, and they're in the emergency room without that individual with them? If we could, I hate to go in the weeds a little bit, but always been kind of curious about how you guys manage something like that.
So what we'll do is we'll check the EMR, the patient's chart, basically, to see if they have any type of documentation already there. Mm-hmm. So, and if they have paperwork already filled out, we will try to carry out their wishes, whatever's present on that paper.
Really cool.
If there isn't any paperwork, we're going to do everything that we can to try to help until we hear otherwise from whether it's the family or whether the patient maybe comes to. But we try to follow patients' wishes as much as we possibly can.
And if something's a very severe accident, or someone gets very hurt, or it's just a very bad, medical event, is there a time where you guys have to make a decision to transfer somebody pretty quickly to a bigger hospital? How does that process work?
So those will be our level 1 traumas. Basically, the physician calls whatever facility we're looking at transferring at and does a doctor-to-doctor report. They accept the patient, and then we immediately set up for transport. That may be by ambulance, it may be by air, but we try to get patients as quick as possible across the river to those level 1 trauma centers.
Very interesting. And right now I'm sure that nurses are needed by the bucket load, I'm sure. And it's right now, is there a big influx in nursing, or are you guys really struggling to staff?
In the emergency department,
we are great.
Really good news. See, that's great news. Is it tough to recruit nurses where you guys are at OSF? Because it seems like, my dad teaches microbiology at Lewis and Clark, and a lot of those are the steps to get into nursing school. But Lewis and Clark has such a great nursing program, and it seems like there's a lot of nurses that get out of school and are ready to work right for OSF or a local hospital. And is that a problem you're facing, a good problem you're facing?
It's wonderful. We're very blessed to have Lewis and Clark, to have SIUE.
Oh, yeah.
Those students do clinicals in our facilities. So what's nice is they're already kind of familiar with us prior to them even graduating. So it's a great kind of recruitment tunnel for us.
We also have a lot of their students staffed as student nurse techs.
Really cool.
Mm-hmm. Yes.
So they work as a tech while they're going through nursing school, and then once they graduate, if they want to, they can apply for a RN position in our facility. And they already have a lot of the orientation already out of the way. So it's a great transition for us and for them.
Well, and they're getting true hands-on learning in that scenario too, and that's that's wonderful. Mm-hmm. And now is what you guys have now, with having a ton of having nursing positions full and having a really good farm system, it seems like, through local schools in Lewis and Clark and SIUE. Is there a nationwide shortage that you've heard? Is there really?
Oh yeah, there's still a nationwide shortage.
Wow.
We're still having shortages in our inpatient side.
Okay.
Still looking for inpatient nurses. So, but nationwide, yeah, they'll continue to be a shortage, I'm afraid, for a while.
Is there anything that OSF or anybody in departments doing to kind of recruit younger people to get into the profession, not necessarily being just RNs, but just in medical care in general? Is that kind of a push from OSF right now?
Yeah, they actually have a high school program that is
that's wonderful,
coming through to kind of look at the different areas of the hospital, and not just nursing. So they may shadow in lab, they may shadow in radiology, they may shadow in quality and safety. Just trying to show them that there's more to healthcare than just nursing. If you're interested in healthcare, you don't have to be a nurse. There's tons of other
many options.
Yeah.
Really cool. Well, thank you both so much for stopping by today. It was a great conversation, and I'm glad that we got to learn a little bit more about the emergency department, because so many times, we're only there whenever things going 500 miles an hour, and to step back and learn a little bit more about it, I hope it helps somebody that hopefully doesn't have to go soon, but if they do, they have a little bit more of some tools to, better their experience or just learn a little bit more of the hard work you guys are doing too.
Well, thank you for having us.
No problem. We'll take a quick break at 9:41. More of our daily show on this Tuesday morning hits you right after this on Riverbender.